All right, so welcome to the second tutorials on 2015 booklet. So we have a serological diagnostic of infectious diseases. It's based upon specific interaction with antigen. Specific interaction with antigen. So what normally interacts with antigen? And you're thinking of what? Antibodies, isn't it? Thinking of antibodies reacting with what? Antigens, because that's what we normally know. Now specify the serological reaction that underlines adhesion of microorganisms when they are affected by a specific antibodies in the presence of an electrolyte. In the presence of an electrolyte. Now, when we talk about adhesion, we are referring to what? Clumping. Clumping. In other words, this is very what? Common in what we call agglutination. So agglutination simply means clumping or adhesion of particles. Adhesion of particles. In some textbooks, when we talk about agglutination, it means that there's some sort of, how do I even put it, Seth? Some sort of fight. Let me put it that way. Yes, some sort of fight. They don't see eye to eye. The antigen and antibodies don't see eye to eye. So they begin to what? To fight against each other. And when they fight against each other, we call it what? Agglutination. Now, when this is occurring inside the red blood cells, inside the red blood cell, we have agglutination, which can lead to what? To hemolysis, or breakdown of red blood cells, or breakdown of RBCs. All right. So in this case, we are having to call what? Agglutination reaction. Agglutination reaction, because an antibody is reacting with what? Antigen. That means they are kind of what? Fighting. So we're having what? Agglutination reaction. Clumping, adhesion. That is your clue. Clumping or adhesion. That is your clue. Adhesion. All right. A 4-year-old child was admitted to an orthopedic department with a displaced shin fracture. Bone fragment reposition requires analgesia. What drug should be chosen? Now, there's a displacement of a bone. Okay. Now, they want to reposition that bone. Can you just imagine how painful that is going to be? Yes, imagine how painful that is going to be. Now, they're saying that what drug should be chosen. Now, if you look at the options over here, almost all of them are all opioid analgesics. Almost all of them are opioid analgesics. And I know many of you be tempted to use morphine because that is the highest form of the opioid medication of opioid that you can give, or the highest form of pain reliever, or the highest form of what? Analgesic that you can give. Yes, I know that. But over here, we are going to go in for what? Promedol. And promedol, it is promedol because it remains the best because it has what we call a spasmolytic effect. Spasmolytic. That means it prevents, sometimes your stomach becomes or begin to have some pains in your stomach due to what? Some spasms. Now, if you take in promedol, it prevents those what? Spasm. So we call it what? Antispasmodic or spasmolytic effect. So that's why we're going to use that one instead of what? Morphine. So morphine. But in the absence of promedol, we can use what? Like I said, morphine is the highest form. Okay. And you don't want the child to start getting used to some pain reliefs, isn't it? So over here, we're going with A. Although if you choose morphine, you wouldn't be wrong either. But the two is present, so we'll choose what? Promedol. All right. Doctors make mostly radial incision during mammary gland surgery. What particulars of anatomical organization make such surgical technique preferable? In other words, anytime we're having what? A radial incision, a radial incision like this way, a radial incision. Why do we do this? Why do we do this? Why do we do that? Why do we do that? That is or what technique? The question is, what particular of the anatomical organization makes such surgical technique preferable? Or why do we use this kind of what technique? Why? Now, in surgery of the mammary gland, the radial incision is preferable because of what? The lobe apexes converge towards the nipple. I repeat, because the lobe apexes converge towards the nipple where secretions are found. So if you look at a lady's breast, they have some. If you look at the lady's breast, almost all the projections come to the nipple or come towards the center this way. Everything comes to the center that way. Then it's all brought at what? So let me just say all the ducts. Let me use the word duct. All the ducts converge at one point where the needle and where the nipple is. So when you squeeze it, all the content begins to be secreted, and they give it to their babies or their husbands and their boyfriends, technically. Okay, but so look at that as it. But in case of giving it to your boyfriend or your husband, maybe some secretion will not come out because the hormones is not due for that. Maybe it won't come out, so they won't get the milk. But the baby, they will get the milk. So learn how to use it. So that's why we use it, because the ducts are also sort of what radial. The ducts are also more of what radial. So that's why we have to use radial incision, and it helps a lot. It helps a lot. So that's over here. We're going with A. It should be A. It should be A, not B. The answer is A, not B. That is A, because all the lobe apexes converge towards the nipple. They converge towards the nipple. So the answer should be what? Should be A. Should be A, not B. A. All right. A 41-year-old man has a history of recurrent attacks of heartbeat, which occur suddenly. Recurrent attacks, so it occurs suddenly. So that the word paroxysms means sudden. Sudden. Now there's profuse sweating, headache. Examination revealed hypertension. Examination is revealing what? Hypertension, hyperglycemia, increased basal metabolic rate, and tachycardia. These clinical presentations are typical for the following adrenal pathologies. So what are you looking at for? We are having what? Recurrent what? Heart attacks. Now, over here, we are looking at a problem with what? With catecholamines. Because they normally lead to arrhythmias. It can also lead to what? Hyperglycemia, hypertension, and all of those kind of things what combined. So we are looking at the problem with what? With catecholamines. And don't forget, we have your adrenal gland, we have the inner part, then we have we have the medulla, the inner part, and the outer one is made up of what? It's called the cortex, isn't it? Then even the cortex, it is divided into what? Into three zones. We call it JFR, if you want to remember it easily. JFR, where the J refers to what? The glomerular part, the F refers to what? The granulosa part, the F refers to what? The fasciculata, the R refers to what? The reticulata part. And all of these have the kind of hormones they produce, isn't it? The outer one will produce what? Aldosterone. The inner one will produce what? Corticosteroids. The inner one, the inner one will produce the sex hormone. Whilst the one inside, which is the medulla, they produce the catecholamines. That's the epinephrine and then the non-epinephrine, isn't it? So when there's a tumor or when there's a problem over here, it leads to this condition that we are having over here. Or this condition that we are having over here. So basically the diagnosis here is what? Pheochromocytoma. And this is occurring what? In the medulla. So we are having hyperfunction of the medulla. So here, your answer is E, hyperfunction of the medulla. Or if you want to be sure of the diagnosis, This is what? Pheochromocytoma. Pheochromocytoma. All right. So the answer is E. A 12-year-old child has developed nephritic syndrome. And I believe we have discussed this thing before. Nephritic syndrome and nephrotic syndrome. We've discussed it before. Now, 2 weeks after the case of tonsillitis, again, we've established before that when you have a problem with tonsillitis, if it is not treated properly or it is not treated, it can lead to what we call what? Post-streptococcal glomerular nephritis. Post-streptococcal glomerular nephritis, because tonsillitis is caused by what? Streptococcus or streptococci. Okay. So if it is not treated properly, it can lead to what? Post-streptococcal glomerular nephritis. And that, I think, is what we're having over here. So we are saying that there's what? There's a sign. So this is a sign of the affected glomerular basement membrane in the kidney. So again, your diagnosis is what? It's post-streptococcal glomerular nephritis. This is your diagnosis. But the question is, what mechanism is most likely to cause this damage? What is the mechanism of what? Action. And over here we have, countless number of times I've discussed with you about hypersensitivity reactions or types of hypersensitivity reaction. We have type 1, type 2, type 3, type 4. And under each type, I gave you guys the diseases that you are likely to find. The diseases that you are likely to find. Now, over here, we are looking at type 3. That's immune complex. Immune complex. And I've explained these things before. Immune complex. And I've explained this thing before. Now, under type 3 or immune complex, we have Artus reaction. Thank you. We have Artus reaction. That's type 3. We have systemic lupus erythematosus. We have serum sickness. We have rheumatoid arthritis. We have post-streptococcal glomerular nephritis. In this case, that is it. We can also talk about polyarthritis nodosa. Polyarthritis nodosa. Polyarthritis nodosa. So all of these form part of what? Of the type 3 hypersensitivity reaction, also known as the immune complex. Please, if you want to know the other ones, kindly watch the videos that we did on pathophysiology or pathophysiology or pathomorphology. You will see them there. They are all there. We talked about them intensively. So the type 1, the type 2, the type 3, all of them, they are all there. So please, over here, we are looking at what? Immune complex. Immune complex. The answer is E. Several minutes after a dentist administered Novocaine for local anesthesia of a patient's tooth, the following symptoms sharply developed in the patient. There is fatigue, skin itching. Objectively, the following can be observed: skin hyperemia, tachycardia, BP has dropped to 70/40. What kind of allergic reaction? Good. So this is also another type of what? Hypersensitivity reaction. Hypersensitivity reaction. And we said when the reaction is occurring within few minutes after being exposed to something, we call it what? We call it allergic reaction. We call it what? Allergic reaction or atopic reaction or anaphylactic reaction or ranging reaction. So this is what? Type 1 hypersensitivity. Type 1 hypersensitivity. Why? Because it occurred right after giving what? Novocaine injection. So this person has developed what? Anaphylactic what? Shock due to the reaction. Anaphylactic what? Shock due to the what? The reaction. So again, another name for anaphylactic is what? Is atopic. That is atopic. Then we have what? The ranging. All of them are all type 1 hypersensitivity hypersensitivity. Type 1 hypersensitivity. So please take note of that. So the answer here is A. A patient with a probable liver abscess was delivered to a surgical department. The patient for a long time had been on an assignment in an African country, and had a recurrent case of acute gastrointestinal disturbance. What protozoa? Guys, look at it. They're talking about protozoa. What protozoal disease can it be? Protozoal disease can it be? For the fact that it can even affect liver, or there's what? Liver abscess. Okay. Then there's what? Gastrointestinal what? Disturbance. So what are you looking out for? What are you looking out for? Definitely you are looking out for what? For amoebiasis or amoebic dysentery. Amoebic dysentery. And this one, it causes bloody diarrhea. So you read that this person will be having diarrhea very often. You'll be having what? Diarrhea. So please take note of that. So here we are looking at what? At A as our answer. Amoebiasis. Work in a mine is known to cause inhalation of large amount of coal dust. So over here, we're going to talk about what? Pneumoconiosis. So the phenomenon whereby inhaled substances causes infection or damage to the lung tissues, we call it what? Pneumoconiosis. So when somebody is exposed to dust, exposed to asbestos, exposed to some substances that eventually destroy the lungs, we call it what? Pneumoconiosis. But this question is not about pneumoconiosis. The question is what? The inhaled dust can be detected in the following pulmonary cells. So when a tissue in general, okay, is being infected or is being attacked, you ask yourself, what cell go to the place of infection? So for example, this is a tissue. Okay. Now this is a vessel, okay? Now inside here, this is a vessel, the blood vessel. And you know blood vessels have white blood cells, red blood cells, platelets, and so on and so forth. Now, this is a tissue, or outside the cell is a tissue. And let's say inside the tissue, we are seeing a substance. Okay, let's say a bacteria, for instance. Or let me just use the coal dust. Now, the question is, what will happen over here anytime there is an injury or anytime there is so this one here is called what? An antigen. The body doesn't recognize this thing. So this is what? An antigen. It's a foreign body. So what substances from the blood, first of all, will enter into the place of antigen invasion? Who can tell me? What cell? Who can tell me? Macrophages. Exactly. Macrophages will enter into the place of what? Invasion, sharply. My friend will say sharply. So sharply, it will move into what? The place of what? Invasion. So that it can engulf around it and swallow it. So it will undergo what? Phagocytosis. Now, macrophages inside the vessel, they are called monocytes. So don't get confused with monocyte and macrophages. So inside the vessel, we call it what? Monocyte. But when it migrates from the vessel into the tissue, we call it what? Macrophage. Now, when macrophage enters there and cannot work properly or is overwhelmed by the antigens that are present, it then now calls the neutrophils, calls the lymphocyte, calls everybody, the cytokines, everybody become what? Activated. That's when we start having what? An inflammation. So over here, which cell or which pulmonary cell can be detected. And over here, we are looking at what? At the macrophages inside the alveoli. Macrophages inside the alveoli. Macrophages. So here, your answer is what? Macrophages. So your answer is A. Is A. Electrical activity of neurons is being measured. They fire prior to and at the beginning of inhalation. Where are these neurons located? The question you should be asking yourself is, where are the respiratory centers? Where are the respiratory centers? Because the respiratory centers, that helps in what? Inhalation and what? In exhalation. So the respiratory centers are always located in the medulla oblongata. They are located in the medulla oblongata and to some part or to some extent in the pons, P-O-N-S, in the pons. And they are all forming part of the what? Of the brain stem. So again, what are the respiratory centers? The respiratory centers are found in the medulla oblongata. So therefore, over here, it is right to say your answer is medulla oblongata. Electrocardiogram analysis demonstrate the cardiac cycle of a human equals to 1 second. It means the heart rate per minute equals what? Now, what is the, let me just say, the normal cardiac cycle or the normal heartbeat of a person? The normal one. So basically, when we talk about the cardiac cycle, cardiac cycle, it is just how the heart is performing. Okay? It's just how the heart is performing from one heartbeat, from the beginning of one heartbeat to the beginning of the next one. That is what we call what? The cardiac cycle. From one heartbeat to the beginning of the next one. And it usually consists of 2 periods. It consists of 2 periods. And I know you know this already. That's why we have the what? The systolic, and then what? We have the diastole, and then we have the what? The systole, or the systolic, and then what? The diastolic. 2 phases. Systolic and the what? The diastolic. So if therefore one cardiac cycle equals 1 second, then the heartbeat per minute. The question is what? Heartbeat per minute. And usually it's around what? 60 seconds. 60. So over here, you are looking at what? At 60. Because every one heartbeat is what? And you don't forget, the normal heartbeat is around what? 60 to 80, isn't it? 60 to 80. So yes, there's 80, but we'll go with the minimum value, which is what? The 60. So at all, you must have what? 60. So don't get confused with what I'm trying to say. We know that normal heart rate is around 60 to 80. Yes, we know that. So you go with the minimum value, which is what? The 60. So at all, within 60 seconds or within 1 minute, you should have what? 60. So over here, we're looking at what? This is A. Sometimes I'm in a hurry to do this editing, so forgive me. So the answer is A, 60. All right. Glomerular filtration of a person who has been starving for a long time has increased by 20%. Glomerular filtration, that means the ability for urine to be filtered. That's the glomerular filtration. And they say that the glomerular filtration of a person who has been starving, that means no eating or fasting, let me put it that way. And I know a lot of Christians and Muslims, they love to fast, something like that. So those who like fasting, now they are saying that one of them has, the glomerular filtration rate has increased by 20%. That means the person is sort of urinating more, isn't it? you are urinating more. Now, the most likely cause of filtration changes in the given condition is what? So, first of all, before I go into the answer, what things controls filtration? What are some of the factors that control filtration? Mention one factor. Faustina, mention one factor for me. We've discussed this.
Please, can you repeat the question?
What factor? Mention one factor that helps to control the movement of fluid from one place to the other.
Osmotic pressure.
Osmotic pressure or oncotic pressure. Good. Arabna, can you remember anyone? Anyone? Did you guys remember hydrostatic pressure? Yes.
Yeah, and renal blood flow.
Thank you. So all of these things are there. So please, so now over here, what are some of the substances, okay, that helps to maintain oncotic pressure? For those who are just joining us, I'm sure you might be confused what I mean by oncotic pressure. Now, assuming this is a vessel, okay, this is a vessel. Inside the vessel, we have some solute that helps to hold water. It helps to hold water. And those solutes, they can either be ions or the electrolyte that you know about, or they can be what? Proteins. So proteins and other electrolytes are the substances that maintain fluid inside the vessel. And the pressure, we call it oncotic pressure. Oncotic pressure. Okay, so in the case whereby you are starving, what it means is that solute inside your blood vessel will decrease. And when solute inside your blood vessel decreases, to be specific, proteins, and talking about proteins, we're talking about what? Albumins. Medicine is sweet. We're talking about albumins. Now, when this substance is decreased, what it means is that now the ability to hold water in the vessel is decreased. So water will begin to flow out of the cells. Water will begin to flow out of the cell. And that is exactly what is happening in this person who is starving. Because there's no protein, there's no albumin, so the water is not able to be held inside the vessel. So it keeps secreting, or it keeps flowing out of the body. So if you realize that the person becomes dehydrated, that's why those people who are fasting, if you see that they become very, very dehydrated, their mouth is dry, their skin is dry. Why? Because they will be peeing a lot. And the reason why they are peeing a lot is because there's a reduced oncotic pressure in the vessel. And that's why over here, your answer is what? Decrease of oncotic pressure, or decrease of blood plasma oncotic pressure. I believe I've established this. But then, if you want to know about the hydrostatic and the other one that I mentioned, please and please again, do well to watch the videos. Do well to watch them. Otherwise, we'll be repeating and repeating. Okay? All right. Cells of healthy liver actively synthesize glycogen and proteins. You remember when we talk about glycogens, right? Glycogens are the storage form of what? Of glucose. Glycogen is the storage form of what? Of glucose. So they say that cells of healthy liver actively synthesize glycogen and proteins. What organelles are the most developed in them? What organelles are the most developed in them? Now, if you look at proteins, for instance, what organelle, or let me just say, what substance is or helps in the synthesis of proteins? Guys, do you remember we talked something about transcription and translation, where we said that transcription takes place inside the nucleus, whilst translation takes place outside or inside the cytoplasm. That's outside the nucleus. So inside the cytoplasm. And we said inside the cytoplasm, we have what we call endoplasmic reticulum. And we mentioned about ribosomes attaching themselves to this endoplasmic reticulum, making them call what? A granular endoplasmic reticulum, isn't it? Exactly. And what's the function of all of these things? Is to synthesize proteins. It's for protein what? Synthesis. So over here, the right answer should actually be what? A granular endoplasmic reticulum. But that's not the only thing that is here. So we can talk about what? The granular, granular. That should be the answer. Granular. Because it contains it contains ribosomes. It contains ribosomes. So this is what? Rough endoplasmic reticulum. They will be the organelles that are mostly what? Developed in this kind of what? Healthy liver cell. So over here, we are looking at what? At B as our answer. B as our answer. We talk about this in our first presentation on 2015. So please do it to visit that video. Atria of an experimental animal were superdistended with blood, which resulted in a decreased reabsorption of sodium and water in the renal tubules. This can be explained by the influence of the following factors on the kidneys. On the kidneys. Again, the atria of an experimental animal were superdistended with blood, which resulted in decreased reabsorption. So that means that there's a substance that is making or that is releasing sodium and water into the what? The outside. So it's preventing sodium to be reabsorbed. That's what it means. It is preventing sodium to be reabsorbed. So that means it is excreting what? Sodium. It is what? Excreting what? Sodium and water. Go away. So what comes to mind? What comes to mind? Definitely you're thinking about what? Natriuretic hormone. Natri means what? Sodium. Uretic means what? Of course, excretion via the urine. So we are looking at what? Natriuretic what? Hormone. Natric uretic hormone. Or atrial natriuretic peptide is the same thing. Peptide. That is NANP. Atrial natriuretic peptide. So always look at the question very well. Analyze it. It is resulting in what? Decreased reabsorption. That means more sodium are being what? Excreted with water. So that means you take a hormone that is what? Sodium excreter. And natriuretic hormone is a sodium what? Excreter. Sodium excreter. Don't go and say it is what? Vasopressin or antidiuretic. The name vasopressin means what? Antidiuretic hormone. ADH. Antidiuretic means preventing urine. So don't go and say this is vasopressin. And of course, aldosterone, you know that aldosterone also leads to reabsorption of what? Sodium. Renin, reabsorption of what? Sodium. So please, don't just go and be talking about all of these things. So here, we're looking at what? At E as our likely answer. A patient with hypertensive crisis has increased content of angiotensin 2 in the blood. Angiotensin 2 in the blood. Angiotensin pressure effect is based on. So the question now is that you must know what the RAS system is all about. Okay. So what to call what? The RAS. Some of you have heard it before. The RAS system. The RAS system. So you don't hear of angiotensin. Think of the RAS system. Now, what is the RAS system? This is renin-angiotensin aldosterone system. Renin-angiotensin aldosterone system. And like in our previous presentation, I told you that renin also helps in the release of what? The aldosterone. Or it helps in the activation of what? Of aldosterone. Okay. And why would this RAS system be activated? Why on earth would this RAS system be activated. Now, the RAS system are activated to increase pressure. Yes, it occurs to increase pressure. That is why, if in people suffering from hypertension, we give them angiotensin converting enzyme inhibitors. ACE inhibitors. You know it, right? I mean, you might have heard of it before. ACE inhibitor. This prevent what? Hypertension. But when the RAS system is activated, it will increase what? The hypertension. And I think that this person is having what? Hypertensive crisis. No wonder he's having what? Hypertensive crisis. That means that hypertension is now what? Getting complicated. Okay. But what is the exact function of this angiotensin? This angiotensin leads to what? Contraction of the arterial muscles. Contraction of the what? Arterial muscles. Arterial muscles. That means it's contracted and it will increase what? The pressure inside the body. So over here, we are looking at what? Contraction of what? The arterial muscles. And this contraction is what activates the renin, or what activates the release of the renin. And don't forget, we mentioned something about what? The macula densa, right? Yes, you can remember it. The macula what? Densa. And we said macula densa senses sodium ion what? Concentration. It senses sodium ion concentration. And when sodium ions are decreased, this renin has to go.
Hello.
Yes.
Please, your network was breaking, so we couldn't hear. Okay, I couldn't hear you.
The whole thing?
No, I could hear him. I think it's yours, not his.
The rest of you can hear me clearly, right?
Yeah, we can.
Okay, but then, for the benefit of our dear friend, let me just rephrase what I just said previously. So I said, when I know you know of macula densa, we talk about it one of our presentations, okay? And we say macula densa senses what? It senses sodium ion concentration. And when it senses that there is no sodium ion concentration inside the urine or passing through the urine, what happens is that it signals the gesta glomerular. You remember the gesta glomerular to secrete what? Renin. Now, this renin, the purpose is for it to also go and what? Activate the angiotensin. And this angiotensin will help to bring further what they call vasoconstriction or contraction of muscles, and also activate the aldosterone system. And when the aldosterone system is activated, it means that it has to what? Release aldosterone. And this aldosterone helps in what? In sodium concentration, or it helps in the absorption of what? Of sodium. So you see how the whole system is working. So that's what we call it what? The RAS system, the renin-angiotensin aldosterone system. Don't worry, when you begin to go to 4th year and 5th year, you understand this system better. All right, but if you take your pharmacology seriously, you understand this thing. All right, so yeah, you're looking at what? At A as your answer. A is your answer. All right. A 43-year-old patient has arterial hypertension. Arterial hypertension. Please, the person who said we're not hearing, I hope now you can hear clearly, right?
Yes, please.
Okay,
Thank you.
good. So a 43-year-old patient has arterial hypertension caused by an increase in cardiac output and a general peripheral resistance. Specify the variant of hemodynamic development of arterial hypertension in the given case. So over here, we have to look at what some definitions and some terms that can help you with your diagnosis. So over here, we're having somebody with what? Hypertension. And I'm saying that hypertension is caused by an increase in cardiac output. Of course, the heart is secreting or is releasing more of what? Blood vessels into the tissues. But to our surprise, there's what? Peripheral resistance. What it means is that there's contraction of the atrials. There's contraction. So if there's contraction or there is constriction, what happens? It means that all the fluid that is being pumped or the blood that's being pumped by the heart will be accumulated in the vessels. And too much blood in the vessels is termed as what? Hypertension, as simple as ABCD. It's termed as what? It's termed as hypertension. Now, let's look at the difference between the following terminologies. Okay. Now, when we talk about hypokinetic, please write this down. Hypokinetic simply means there's an increase in peripheral resistance. Increased in peripheral resistance. Hyperkinetic, hyperkinetic means increased in cardiac output. So I mean, in this case, we have both increase in cardiac output and increase in peripheral resistance. And that brings us to the next term known as eukinetic. Eukinetic. And eukinetic means increase in both cardiac output and peripheral resistance, as simple as ABCD. Again, it means increased cardiac output and increased peripheral resistance. So looking at our option over here, and want to look at the mechanism of the development of this hypertension, it means that there is both increase in cardiac output, because actually there can be increase in cardiac output, okay, and there's no increase in peripheral resistance. It's possible. And it's also possible that cardiac output could be normal, but there's increase in the resistance. Good. So please take note of that. But in this case, we're having both conditions occurring, and hence our answer is what? Is eukinetic. 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 Don't go and use combined as a layman, explanation that it is both means combined. I know some of you might be thinking that way, but the right term is eukinetic. All right. A patient has been hospitalized with a provisional diagnosis of hepatitis B infection. Hepatitis what? B infection. Serological reaction based on complementation of antigen with antibody chemically bound to peroxidase or alkaline phosphatase has been used for disease diagnosis. Name this serological what? Reaction. So this one, you just have to know that this one we're looking at what? The immune enzyme analysis. And immune enzyme analysis is used to detect the presence of either a specific antigen or a specific antibody in a patient's blood sample. I repeat, the immune enzyme analysis is used to detect the presence of either a specific antigen or a specific antibody in the blood. Now, the common enzyme that they use is the peroxidase, the alkaline phosphatase, and even the glucose oxidase. So these are some of the enzymes they use in analysis of what? Immune enzyme, or in doing immune enzyme analysis. So over here, we want to look at what? The antigen or the specific what? Antibody present. So here, we're looking at what? At immune enzyme analysis. Immune enzyme analysis. So the answer is what? Is B. A surgeon has to find the common hepatic duct. Common hepatic duct during operative intervention for the treatment of concernment in the gall duct. When we say concernment, it means that there is what? Some sort of what? Stones, okay? Some stones or some calculi inside the gallbladder or inside the gall duct. Now, the common hepatic duct is located between the leaves of what? So this one is anatomy. So where can we locate the common hepatic duct? That is the question. That's the question. Where can we locate the common hepatic duct? And the common hepatic duct, if you have, please, this is an assignment. Go and look for the anatomy of it so that you can know it better for yourself. But basically, we are looking at what? The hepatoduodenal ligament. Hepatoduodenal ligament. Hepatoduodenal ligament. So please look at it very well. when you look at your, or when you get your, how do you call it? Atlas, or you can even Google it. So here you're looking at what? At A as your answer, hepatoduodenal ligament. All right. It is known that the gene responsible for development of blood groups, according to the ABO system, has 3 allele variants. Existence of the 4th blood group can be explained by the following variability form. By the following what? Variability what? Form. Now, what blood group is blood group 4? Who can tell me? What blood group is blood group 4?
AB.
AB. Good. AB. So we have a combination of what? Blood group A and blood group B. Blood group III is what? Blood group what? B. II is blood group what? A. I is blood group what? O. So please, that is just by the way. So now we are having what? Now this one is what? This one will be what? A single blood group B, blood group A, blood group O. But in blood group 4 or in AB, it's a combination of blood group A and blood group B, isn't it? And that phenomenon, we call it a combinative type of variability. That means it has both both A and B. So call it what? A combinative sort of what? Blood group variability. A combinative blood group variability. And both of them are dominant. Okay. Both of them are dominant. Now, in blood group, this one, it could be BB or BO or BO. But, so in BO, blood group B is the dominant gene. So that one would express itself more. Okay. That's why over here, we will also say that this is not what? A combinative type. Because the other one is not expressing itself. But in AB, both A and B are expressing themselves. In blood group II, that is blood group A, it also has AA or AO. But again, O is a recessive gene. It's a recessive gene, so it doesn't express itself. And that's why over here is not also a combinative. But this is a combinative. Of course, blood group O means it is OO. Now, both recessive, well, of course, it will start what? Prevailing, isn't it? Because both of them are recessive. So it will start showing. Aha. So this is what? Type 4 variability. Type 4. Sorry. Combinative type of what? Variability. So your answer is C. Your answer is C. Now, we'll talk about genotype and phenotype. Genotype is the genetic makeup of a cell. Phenotype is the physical representation of that genotype. Medicine is sweet. I repeat, the genotype, for instance, when I say AB or BB or BO, these are genotypes. These are what? Genotypes. Sometimes when people come to the hospital and I ask them, do they know their sickle cell? They start telling me, do you mean genotype? I'm saying, no. Do you know your sickle cell status? The thing I'm talking about genotype. Genotype can be different, but just because they don't know, oh, this is AA, you are AA or AS or SS. AAAS or SS. These are all what? Yes, indeed, these are what? Genotypes, but genotypes can mean different things. So this genotype, these blood groups are also what? Genotypes. So if I say, what is your sickle cell status? And you're telling me that, do you mean genotype? It's either you have it or you don't have it, isn't it? So this, of course, healthy, this is a carrier, this is what? Sickle. So yes, I have sickle cell, as simple as that. And that is what? The phenocopy or the phenotype. Aha. Please, that is just by the way. Now, when measuring power input of a person by the method of indirect calorimetry, the following results were obtained. Oxygen consumption is 1,000 mils and carbon dioxide production is 800 mils per minute. The person under examination has the following respiratory coefficient. So what you need to do is know how to calculate respiratory coefficient. And respiratory coefficient, RO, I hope you guys are writing it though. RO is equal to what? The volume of carbon dioxide produced, so CO2 produced over the volume of oxygen consumed. I repeat, volume of carbon dioxide that was what produced over volume of oxygen that was what consumed. And again, each and every value can even tell you the kind of food that it is. But before that, let's go to the question. Now, what is the oxygen consumption? That is 1,000. Or oxygen that's consumed is 1,000 mils. What is the carbon dioxide that was produced? 800, isn't it? 800. So what is your respiratory coefficient? Of course, 2 zeros will cancel these 2 zeros. So we have 8 over 10, which means 0.8. So the answer here is what? 0.8. 0.8, which means your answer is what? Is A. Is A. Is A. Now, then again, like I said, every value corresponds to a particular kind of what? Food. And I'm saying this because you might meet it somewhere in your Krok. Okay. Now, if the food consumption or the food that was taken in was carbon dioxide, was carbohydrate, the value is 1. Value would be 1. Value would be 1. Now, with fat and oil, if the food is fats or made up of fatty food, we have 0.7. Respiratory coefficient is 0.7. And then protein or proteins is what? 0.8. Please take note of these things. I repeat, carbohydrate will always give you a respiratory coefficient of 1. Fat will give you 0.7. And proteins will give you what? 0.8. 0.8. So over here, the person is using what? Proteins. So the answer here is what? Is A. All right. On examination, a newborn boy's external genitalia. On examination of a newborn boy's external genitalia, a fissure in the urethra opening on the inferior. Guys, we've discussed it already. We said if it is superior, we call it what? Epi. If it is inferior, we call it what? Hypo. That's all. So over here, we are looking at what? At hypospadia. Hypospadia. This is just what? An opening, a malformation. An opening that is not supposed to what? To be there. Okay. All right. So the answer is what? Is D. Hypo. But if this was what? Supposed to be what? Superior, your answer is what? Is epispadia. Poisoning caused by mercury chloride occurred in the result of a safety rules violation. In 2 days, the patient's diurnal diuresis became 620 mils. The patient developed headache, vomiting, convulsion, dyspnea, moist crackles are observed. Name this pathology. Don't forget, for them to give you, of course, they've told you that it's a poison caused by what? By a mercury chloride. Caused by a mercury chloride. Now, these things can affect a lot of organs. Now, when they start mentioning to you about, how do you call it? Kidney problems, please again, start looking at it critically. Critically. And we know mercury can affect the kidney adversely. So over here, we are having a case of what? Acute renal failure. Because this, how do you call it? Mercury chloride affects the kidney a lot. it affects the kidney a lot. Of course, apart from the fact that it can also affect the CNS. Of course, it can affect the CNS as well. So over here, we are looking at what? At D. This acute. It's acute because it's a poison that occurred recently, okay? In chronic, they'll tell you that the person has been exposed to it for a very long time or as an occupational hazard, they will tell you. But this is not an occupational hazard. This is a poison. The person has been poisoned. So the kidney will be affected a lot. Now, in uremic coma, basically, we're dealing about what? About ammonia or uric acid. So please don't get all of them twisted. So here is D. For people adapted to high external temperatures, profuse sweating is not accompanied by loss of large volumes of sodium chloride. Guys, listen to it again. For people adapted to high external temperatures, profuse sweating is not, it's not accompanied by loss of large volumes of sodium chloride. What it means is that sodium chloride is not excreted, it is retained. Sodium chloride is retained. So the question is, what hormone retains sodium chloride? Anybody can answer. What hormone retains?
Aldosterone.
Aldosterone. I love you guys. Aldosterone. It retains, it prevents sodium excretion. Now, if you go and take natriuretic, it means sodium should go out. Good. If you say vasopressin, it deals with water. That's preventing water. So please, don't get all of these things twisted. Medicine is just fun. So please understand the question. So here, your answer is what? Is D. Because the question is what? This is caused by the effect of the following hormones. And of course, you're looking at what? At D. Along with normal hemoglobin types, there can be pathological ones in the organism of an adult. Name one of them. Name one of them. Of course. But don't worry, let me just tell you the types of hemoglobin, okay, before I come to the answer. Because we are learning as well. Let me tell you the type of hemoglobin. I know some of you already know the answer. But we have hemoglobin A. And this makes about 95 to 98% of hemoglobin found in adults. Hemoglobin A. Most of us have hemoglobin A. Okay. Now it contains 2 alpha chains and then 2 beta protein chains. This is just that I want to add to it. We also have what? Hemoglobin A2. And this made up about 2 to 3% of hemoglobin found in adults. Again, it has 2 alpha chains and then 2 delta, not beta, delta chains. We have hemoglobin F. This is primarily hemoglobin that is produced by the fetus or the fetus. And its role is to transport oxygen efficiently in a low oxygen environment. So this is found basically in children or in fetus. Then we have hemoglobin S. That's what we talk about. I mentioned some things about you a few minutes ago, talking about sickle cell and talking about your status, sickle cell status, isn't it? So we have what? Hemoglobin S. And this hemoglobin S is found in people with sickle cell disease. And this is pathological. So over here, we are having what? E. Don't forget, we also have what we call thalassemias. So in thalassemia, you are having the globulins, or we are having the beta chains and then the alpha chains being a problem. But this question is not relating to thalassemia, okay? But for the benefit of learning, you can go and then read on thalassemia, Thalassemia, S-E, blah, 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 blah. Thala. Please, I'm forgetting my spelling. So, thalassemia, okay? Try and get it. Thalassemia. Good. So Thalassemia. Thalassemia. So go and look for it. So over here, the pathological one is what? Is hemoglobin S. All right. An emotional stress causes activation of hormone-sensitive triglyceride lipase in the adipocyte. What secondary mediator takes place in this process? In other words, have you heard of phospholipase enzyme before? Maybe. But usually, we have on hormone-sensitive triglyceride lipase. Hormone-sensitive triglyceride lipase. The question is that what do they do? How did they function? Okay. What they do is that they normally activate what we call cyclic adenosine monophosphate. Cyclic adenosine monophosphate. And this is used as an intracellular signal transduction. Intracellular signal transduction. And this helps to activate what? Substances in the body. As simple as that. Substances in the body. I'm looking forward to making some videos on some of these enzymes and hormones and topic by topic to be specific. And since you guys are in third year, by the time you get to fourth year, I will have developed something for you guys so that whilst in fourth year, you can understand some things, some concepts, how enzymes work. We have what we call the primary mediators, secondary mediators, and then the tertiary. We have all of these things. You need to know all of these things. You need to know them. Okay. But of course, time will not permit us to dive straight into all of them. Good. So over here, we are definitely looking at what? At B, cyclic adenosine monophosphate. And this helps to activate other substances in order for things to get moving. All right. A patient has been diagnosed with acaptonuria. Choose an enzyme that can cause this pathology when deficient. That means that if you don't know the meaning of this, probably your answer will be what? Will be wrong. So, usually, acaptonuria is also known as hemogentisuria. Hemogentisuria. That's another name for acaptonuria. And this is a rare inherited genetic disorder in which the body cannot process the amino acid phenylalanine and then thyroxine. They cannot. So there's a disorder with this enzyme, with this amino acid, phenylalanine and then what? Thyroxine. Phenylalanine and thyroxine, which are all what? Protein. Okay, which are all protein. But of course, what is responsible or the hormone that helps in all of these to help break down this thyroxine and then the phenylalanine is what we term it as what? Hemogentisate. Homogentisate, not hemo. Homogentisate. So that is the hormone that is responsible or that helps us to break down this tyrosine and the phenylalanine. So when this enzyme is deficient, what it means is that the function would be impaired. So usually people with these things have a dark urine. Very dark. So here your answer is what? Is E. All right. It's E. Now, as a result of a continuous chronic encephalopathy, that means chronic brain infection or brain disease, a patient has developed a spontaneous motions and a disorder of the torso muscle tone. There are the symptoms. These are the symptoms of the disorder of the following conducting tract. So again, we want to look at what first of all, there's a chronic problem in the brain, isn't it? But here we're talking about what? Spontaneous motions and a disorder of the torso muscle tone. And usually, we are going to be dealing with what? The red nucleus. The red nucleus. The red nucleus. The red nucleus. Okay. Now, inside the red nucleus, of course, in a way, this is connected to the what? To the cerebellum, because you know that motions and then orientation deals with what? With the medulla, with the cerebellum. Cerebellum. It deals with the cerebellum. Okay. So you want to look at the connection between these two. And that one, we are going to look at what? A problem inside what? The red nucleus. And so therefore, we call it rubrospinal tract. Rubrospinal tract. And this is a descending pathway which originates in the red nucleus, and it descends into the spinal cord, into the spinal cord. So, and again, it connects with the cerebellum. And this is somewhere around the midbrain. Okay, so the midbrain. So please take note of these things. Some of these things, you need diagram. That is why it's kind of difficult to elaborate on it. But maybe in future, I will try and start bringing in diagrams so that some of these things can be visualized and be more appreciated. All right. So here we're looking at what? We're looking at C as your answer, rubrospinal. A child is 10 years old. The following presentation have developed. There's a sharp pain during swallowing, swollen neck, body temperature up to 39. Guys, look at this. There's a bright red, finely papular rash all over the body. Pharynx and the tonsils are sharply hyperemic. Crimson tongue. On the tonsil surface, there are isolated grayish necrosis foci. What disease it is, or what disease might it be? What disease might this be? And definitely, you are looking at what? Scarlet fever. And this develop in people who have strep throat. We can see that this person is having what? Strep throat with infection. It develops in people with what? With strep throat. So anything you're thinking about what? Skin rashes or things like that, accompanied with what? Strep throat or tonsillitis or something like that, please think of what? Scarlet fever. And again, to add up to it, or basically, it is characterized by the presence of a bright red rash. Bright red rash. So that means the rashes there are very, very reddish. Very, very reddish. And of course, it's accompanied with fever and the sore throat that I mentioned about. Okay. So basically, this is what we're looking at. And it's also very common in children between 5 to 15 years. Very common in them. So over here, we are looking at what? At the scarlet fever. A patient suffers from intermittent fevers and normalization of body temperatures that occur during the day. Guys, what disease can you be thinking about in this kind of cases? Whereby fever is alternating with perhaps normal fever, then before you realize you are sweating. What kind of infection can you think about? It's very common. Can anyone tell me? Oh, it's very common in Africa.
Malaria.
Malaria, exactly. So this is very, very specific for what? Malaria. Whereby there is fever, then it goes, it comes, it goes, and comes, and goes, and comes. Now the temperature rise is observed regularly every 4th day. Specify the type of what? Temperature what? Curve. Specify the type of what? Temperature what? Curve. But usually when temperature is going up, down, sweating, then this and that, basically you are thinking of what? You are thinking of what? Malaria, like you already said. But over here, what type of temperature curve? So that's what we're going to look at. Temperature what? Curve. And we have a lot of types of temperature curves. So I'll just go through a few of them so that you know what it is. But over here, we're looking at what? Temperature intermittent. Even if you don't know at all. For the fact that they are telling you that this is intermittent fever, please, your answer is what? Intermittent. As simple as that. Intermittent fever. So your answer is already in your question. So this is what an intermittent what? Fever. Like I said, it is alternating fever that is caused by rising period of temperature, which alternates with the period of what? Normal temperatures. Like I said, this fever is common in malaria. We have continuous fever or febris continua. Febris continua. Febris continua. And this is a permanent fever. Permanent fever. As simple as that. Very common in people with Croup pneumonia and even abdominal typhus. Croup pneumonia and abdominal typhus. We have febris recurrent. Like the name is telling us, it's a recurrent what? Fever. Recurrent what? Fever. Very, very common also in malaria and recurrent what? Typhus. Common in malaria. So it keeps coming. It goes and comes, goes and comes, goes and comes. That's what recurrent what? Fever. They also have what? Favorite hectica. This is an exhausting fever. For the name, hectic. When the patient goes to work and comes and says, oh, I'm feeling it's just a hectic day. So tell you that this fever is very, very exhausting. Very, very exhausting. Very, very exhausting. And usually it's very, very common in people suffering from sepsis. People suffering from sepsis. People suffering from tuberculosis and malignant tumors. So sepsis, tuberculosis, very, very frustrating fever. Very frustrating. Okay, then we also have what? Remittents. Febris remittents. And these are indulgence fever. Indulgence fever. What means that it fluctuates between the morning and the evening. Also very common in people suffering from sepsis and abdominal typhus and things like that. So basically, these are the things that you need to know about the different types of what? Fever. Please, if you miss anything, just do your best and rewatch the video again. Okay, watch the video again and try to also research on them, all that I've said, so you can understand these things what better. So the answer is B over here. All right. I like blood groups. I don't know why. Question on blood groups, I just love it. Now, a woman with blood group B, rhizos negative. Is it rhizos negative or rhizos? But I think rhizos negative. Rhizos negative blood group gave birth. Sorry. The rhizos negative blood group gave birth to a child with what? Blood group 2, known as what? Blood group A. Now, the child is diagnosed with hemolytic disease of a newborn caused by rhizos incompatibility. Guys, do you remember we talked something about a woman being negative and giving birth to a child, right? Yes. So now what blood group and rhizos can the father have? Definitely, at all costs, you must know that for the baby to have rhizos incompatibility from a mother who is Rh negative, it means that the baby must have what? Positive rhizos positive. And of course, this rhizos positive will come out from what? From the father. Touch now. From the father. Now let's do some small calculation over here. Now we have blood group what? Blood group B. And I've told you guys countless number of times that blood group B means what? Either BB, taking my time. These are alleles, okay? Either BB or BO. That's blood group what? That's blood group what? B. Exactly. So this is the mother's blood group. Now let's come to the father's blood group as well. So the father's blood group, okay, that's what we're actually trying to what? Look out for. But you ask yourself this question. Ask yourself this question. Under what condition would a child have A? They've told you that mother is B. Mother is B. So if anything at all, at least B should be there, isn't it? So now, if anything at all, there might be B somewhere there. But here the case, the child has no blood group B. So that means that this genotype can be taken out. this BB genotype, that means the child did not inherit any B from the mother. But the child can inherit O from the mother. And O is a recessive gene. O is a recessive gene. So what it means is that the father could have had the A, or the A could come from the father. So either the father is AA also, or AO. Good. So the mother is BB or BO, father could be AA or AO, because that is the only conditions by which a child can have A. And talking about that, after the B here, the blood group BB here, it can be possible. Or the genotype BB here cannot be positive. Cannot be possible. Okay, cannot be what? Possible. So over here, so the child definitely got the O from the mother and got any of the A's from the father. And by this means, the child is what? Is A. Because O is always what? A recessive gene. So A will express itself. So then definitely, the father blood group should be A. And like I said, since there's rhizose incompatibility, it means the child was positive. Good. So that means the father is what? And the child being positive means that he or she got it from the father. So this is what comes what? A positive. A positive. So let's now look at our option over here. So here, your answer should be what? A positive. A positive. So your answer is what? Is D. A positive. Very interesting, isn't it? It's just lovely. Lovely. A patient is diagnosed with hereditary coagulopathy that is characterized by factor 12 deficiency. So this is actually what? Hemophilia A. Hemophilia A. Some of you might have heard it before, or you know it already. Hemophilia what? A. Hemophilia
Factor
A.
12?
Sorry?
You said factor 12.
Factor 8. Oh, I said factor 12. Sorry. This is factor 8. Factor 8. Factor 8. Caused by what? I mean, the name of the disease is called what? Hemophilia A. Then if it is factor 9, we have hemophilia what? B. Good. Now specify the phase of blood clotting during which coagulation will be disrupted in the given case. So over here, we are having a problem with what? With coagulation. In other words, coagulating what? Factors. Coagulating what? Factors. So over here, I think the right answer might not even be present. It might not be present because what would be disturbed would be what? Coagulation. Or would be, let me put it, how do I put it? The coagulation cascade could be what? Disturbed. Coagulation cascade. Because factor 8 is needed to activate the factor 8. Okay, factor 8 is needed to activate factor 8. And factor 8 will in turn activate factor 9. So when this factor is not there, definitely there might be a problem with it, isn't it? But then, Krok is of the view that this could be what? Thromboplastin formation disturbance. And thromboplastin is actually factor 3. It's factor 3. So if we are having a deficiency of factor 3, then yes, thromboplastin will be what? Will be impaired or will be what? Disturbed. And for that, I will have gone to, directly, this is correct, no problem. But because of factor 8, I'm having my reservation. But of course, I stand to be corrected, okay? We are all learning. I stand to be corrected. That's what over here, for Krok, and for what I've just explained, if this was to be factor 3 deficiency, then yes, we have no problem with the answer. But factor 8, that's what my problem is. So coagulating time will be affected because it will take time for things to happen. All right. So over here, we're looking at what? Thromboplastin formation, according to Krok. But like I said, I stand to be corrected. All right. So here, your answer is D. Your answer is D.